Hello, we're glad you've joined us for this live webinar, The Evolving Role of Image-Guided Prostate Cancer Targeting and Ablation, Moving Towards Personalized Medicine. I am Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. This presentation has been approved for continuing educational credits. If you want to obtain the credits, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to the continuing education page where you can select a speaker, click on the CE CME button, and it will take you through the process to obtain your certification. Let's get started. You can pose questions to the speakers during the presentation while they're fresh in your mind. To do so, simply type them into the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. We'll try to get to as many questions as we can, and we'll follow up if we don't have time today. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience any technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at lower left. I now present today's speakers, Stacy Loeb, MD, Assistant Professor of Urology and Population Health at the NYU School of Medicine, specializing in prostate cancer. Rajan Gupta, MD, Assistant Professor of Radiology, Director of the Abdominal Imaging Fellowship Program at the Duke University School of Medicine, and a faculty physician in the Duke Cancer Institute. And Thomas Polasic, MD, Professor of Surgery, Director of the Society of Urologic Oncology Program, and Director of the Genitourinary Program on Focal Therapy at the Duke Cancer Institute, Duke University Medical Center. To learn more about Drs. Loeb, Gupta, and Polasic, click on the still image in the right corner for more information to go to the LabRoots site. Dr. Loeb will now begin her presentation.
Hi, my name is Dr. Stacy Loeb. I'll be discussing trends in the use of active surveillance for prostate cancer, patient selection, and monitoring. Prostate cancer screening has been an issue of major controversy for the past several years. There are several proven benefits to prostate cancer screening, including a reduction in metastatic prostate cancer death rates. However, there's also some harms associated with screening. The PSA blood test, which is used for screening, is not perfect, leading to unnecessary biopsies, as well as overdiagnosis and overtreatment of some insignificant prostate cancers. As a result of some of these issues, in 2012, the U.S. Preventive Services Task Force actually issued a grade D recommendation against prostate cancer screening with the PSA blood test. And the evidence they listed is that for every 1,000 men screened, there would be one fewer prostate cancer death, but many more men with incontinence or erectile dysfunction due to prostate cancer treatment or other side effects of treatment. As you'll notice in this box, though, all of the side effects that they're listing for the PSA blood test are actually side effects of prostate cancer treatment, not of the actual PSA test itself. So, my belief is let's not throw out the baby with the bathwater. The PSA test has been shown to reduce metastatic prostate cancer and prostate cancer death, but there are some negative aspects as well which we need to deal with, including the false positive test results and overdiagnosis and overtreatment. So, this is the introduction to my talk, which is on active surveillance as an important way to reduce the burden of overdiagnosis, because it turns out actually that many low-risk prostate cancers can be safely monitored and don't need immediate treatment. So you can either delay or avoid altogether the need for aggressive prostate cancer treatment in patients with low-risk disease. This is a great quote from Dr. J. Smith from Vanderbilt. Treatment or non-treatment decisions can be made once a cancer is found, but not knowing about it in the first place surely burns bridges. So we do need screening still to diagnose the high-risk cancers in time for cure. Prostate cancer is the second leading cause of death in the U.S. But for those men who do have a low-risk cancer, there's no reason that it's necessary to rush into immediate treatment. The problem is that active surveillance, or this approach of monitoring the cancer conservatively, was historically underutilized in the United States. As you can see from these statistics, up until even 2009 across the United States, less than 20% of low-risk patients were receiving active surveillance. But this has started to change. In fact, there are a few recent studies from different parts of the United States showing 40 to 50% of low-risk patients now are receiving active surveillance. So actually, we're doing a much better job of reducing the overtreatment of prostate cancer. Recent data from New Hampshire in 2011 showed 42% of low-risk patients getting active surveillance. In Michigan, from 2012 to 2013, 49% of low-risk patients received active surveillance. And in the U.S. Capture database, which is a nationwide database, 40.4% of patients from 2010 to 2013 with low-risk prostate cancer were receiving active surveillance. These trends have been seen in other countries as well. These are some data from Toronto, Canada, showing at the top low-risk disease. And what you can see is back in the 2000 to 2008 range, more than 40% of all of this prostate cancer surgery was for low-risk patients. And even as of 2012, this was down to 13.6% of the prostatectomies only were for low-risk disease. So we are doing much fewer surgeries and much more active surveillance now for low-risk prostate cancer. These trends have been seen in many other countries around the world as well. In Australia, from 2009 to 2013, 37% of low-risk patients received active surveillance. And in Sweden, from 2007 to 2011, 59% of very low risk and 41% of low risk cases were on active surveillance. So this is a great improvement. This is what I told Medscape recently. The era of active surveillance for prostate cancer has arrived. So some of the initial concerns of the U.S. Preventive Services Task Force about widespread overtreatment of low-risk prostate cancer really have improved substantially over the past few years. Now, let's talk about what are the objectives of active surveillance. So our goal is really to identify men with non-lethal prostate cancer who can delay or avoid treatment and its associated complications. But nevertheless, we still want to monitor them. We want to detect progression if it occurs so that we can offer treatment in a delayed fashion, but still within the window of curability. So it is an active process designed to keep tabs on what's happening with the cancer. Traditionally, the way that we've done this is to continue to check the cancer through traditional tests. These include the PSA blood test, determining what is the PSA level, clinical stage, or the prostate digital exam with a finger, and looking at the biopsy features, the grade of the cancer, which is measured as the Gleason score, and the extent of the disease, how much cancer is there on biopsy. So here's the issues. As I mentioned, we do use PSA as a way to monitor patients during active surveillance. The problem is that changes in PSA during the course of surveillance are not totally reliable. We did a study at Johns Hopkins looking at men there on active surveillance, and overall at 3 years, 35% of them had biopsy reclassification, meaning the biopsies showed higher grade cancer or more cancer. But the problem is there was no relationship between the changes in PSA with the bad biopsy findings. So we concluded actually that just looking at trends in PSA is not actually reliable enough as a predictor of who has progression during active surveillance for prostate cancer. So biopsies really are necessary in order to check on the cancer. The problem is that biopsies are an invasive procedure with potential risks. This is a study that we did in patients from the U.S. SEER Medicare database, looking at men all across the United States, more than 17,000 men who had a prostate biopsy compared to controls. And as you can see, there was an increasing risk of complications over time in men undergoing prostate biopsy. There's the concerns that we have about prostate biopsies are this increase in infection. It can also have some other minor side effects, like some minor blood in the urine, blood from the rectum, blood in the semen. Urinary symptoms can occur. These are usually transient, but the process can have some discomfort and anxiety for the patient. The other problem with repeated prostate biopsies is there is this controversial association, possibly with an increased risk of erectile dysfunction, either due to some kind of inflammation around the prostate from putting needles in the area on multiple occasions. Not all studies have borne this out, and it's really difficult to study this, but it is something that I think is worth mentioning to patients. And of course, people don't enjoy undergoing repeated biopsies, so it can be a source of non-compliance where men may not come back as they're supposed to check on the cancer because they don't want to have another biopsy. So these traditional approaches of monitoring patients during active surveillance, which I mentioned, including the PSA blood test, the prostate exam, and prostate biopsies, are not perfect. Just having one of these tests doesn't classify patients perfectly. Following the changes in PSA over time is not reliable. And relying on biopsies involves risk to the patient and significant burden. So all of this has set the stage for a critical need for better ways for us to actually do active surveillance, non-invasive ways to try to monitor patients during active surveillance. So what are some of the new testing options that we have in active surveillance? One of them is to use imaging, such as MRI, as a way to check if there's a significant cancer present. There's also some new marker tests that have been studied in active surveillance, including the Prostate Health Index blood test, the PCA3 urine test, and some tissue tests called Prolaris and Oncotype DX. These different types of tests have been summarized in a couple of papers if any of you may be interested in more information. This is a systematic review of some of the clinical variables and biomarkers that are helpful in selection for active surveillance, and another systematic review done by some colleagues about the use of MRI in active surveillance, both of these companion papers in European Urology this past year. So just to summarize, MRI is probably one of the greatest advances that we've had in prostate cancer over the past few years, and is particularly useful in the setting of helping to select patients for active surveillance, because it turns out that if you see a suspicious tumor in the prostate on an MRI, there's a much greater risk of having reclassification on a repeat biopsy. Reclassification meaning an increase in the grade of the cancer or the extent of the cancer, so 2 to 4 times greater risk. So reclassification risk can really be predicted by MRI, and in fact, in the UK, it's even recommended that MRI should be done before the patient confirms that they want to do active surveillance, as a way to make sure that there isn't any more aggressive disease present that wasn't detected on the initial biopsy. MRI may also be useful in a serial fashion for monitoring patients during active surveillance. As yet, not a lot of research has been published on this, but this is a very active area of investigation, trying to figure out some kind of consensus on what constitutes progression on an MRI, how much change in the size of the tumor or what parameters on the MRI tell us that the cancer is progressing. So I see this as something that's likely to come to the forefront in the next few years. Much greater use of MRI and much more evidence on how we can use it as a way to monitor patients instead of doing so many repeat biopsies. Another test that's been studied in active surveillance is a new marker test, a new blood test called the Prostate Health Index, or PHI. This is basically just like a new and improved version of the PSA test. It actually includes the PSA test and two other subforms of PSA called free and pro PSA. PHI has been extensively studied in the initial detection setting. So for men who are considering a prostate biopsy, the prostate health index is better than PSA. It actually does a better job predicting who will have significant prostate cancer on biopsy. And it was FDA approved in 2012 for that particular decision point. So just to explain this a little better, we've known now since the early 1990s that PSA circulates in the body in free form and complex to proteins. So that's the pie chart on the left. But what you now can see on the right is that the free form actually is comprised of several different isoforms. And so this has all been discovered more recently, and this particular form called pro-PSA is more specific for prostate cancer. So the goal of this prostate health index is to combine all these different types of PSA in a ratio to determine whether the amount of each of these is something that's concerning for prostate cancer. So this is what the report looks like. Basically, you get your PSA, the pro-PSA, and the free PSA, the three parts separately, and then you get a combined score that tells you the risk of finding prostate cancer on a biopsy and predicts the risk of aggressive disease. So this has been studied now in a couple of active surveillance programs, and it's been shown that the prostate health index at the beginning of surveillance or during the course of active surveillance predicts the risk of progression during the course of surveillance. So this was found at Johns Hopkins and later validated in a Japanese active surveillance program. So now we do have this as a blood test and the MRI as an imaging test as some other new options that could be used to monitor patients. PCA3 is a urine test. This has also been looked at in active surveillance. Initially, this was FDA approved for men who don't have cancer, who had one negative biopsy to try to predict the likelihood of finding prostate cancer on repeat biopsy. Unfortunately, some studies have been done looking at this PCA3 urine test in active surveillance and did not find a benefit. This was looked at in two different active surveillance populations at Johns Hopkins and in the Canary program, and the PCA3 urine test did not predict who had progression. So far, not such encouraging results on that end. There are also some tissue tests. One of them is called Prolaris. This is a panel of cell cycle progression genes. You send the biopsy tissue to the company, and it measures how much cell cycle progression is happening to help stratify the risk of recurrence and of prostate cancer death. So this is what the report comes back looking like. It tells you what the 10-year risk is of prostate cancer death for that patient if they're managed conservatively. So if that number is very high, then probably this person would not be a good candidate for active surveillance, whereas if it's very low, then they may want to consider starting off with active surveillance. A similar test, but using different genomic markers, is called Oncotype DX. As with Prolaris, you send the biopsy tissue to the company and they check for a totally different set of genes from 4 pathways involved with prostate cancer to predict the risk of adverse pathology. And as with Prolaris, this can help to further risk classify patients beyond those tests that I just mentioned, the PSA, the digital prostate exam, and the Gleason score. So this is what the report looks like for Oncotype DX. It tells you the risk that you will have favorable or unfavorable pathology in this patient. So if this score shows that there's a great chance that the pathology is favorable, then that patient may want to choose active surveillance. So a little bit of a different type of reporting than Prolaris, but both of them with the goal of giving the patient more information to help decide whether to have treatment or not. So in summary, the era of active surveillance has arrived. It's really increasing in use around the world for low-risk prostate cancer. Patient selection based on standard factors, though, has been somewhat limited because looking at changes in PSA isn't very reliable, and doing a lot of serial prostate biopsies has significant risks and burden. So we really do need better ways to select patients and follow them without having to do frequent prostate biopsy. Some of the emerging options for this include the MRI, which has really improved a lot over the past few years, and the new prostate health index blood test. So hopefully some of these tests in the future can be used in combination to try to reduce our reliance on prostate biopsy. And this is a very active area of research, so I expect that we'll continue to get much better with the process of active surveillance over the years to come. Thank you very much.
Hi, I'm Rajan Gupta from the Department of Radiology at Duke University Medical Center, and I'm happy to be here to talk about the emerging roles for multiparametric MRI in the setting of prostate cancer. So what I want to do over the course of the next 15 to 20 minutes is talk about the diagnosis and workup of prostate cancer with multiparametric MRI, talks about the value of multiparametric MRI in some key clinical scenarios, and then finally talk about how to integrate mpMRI into focal therapy, specifically what the role of multiparametric MRI is in the setting of biopsy and treatment guidance, as well as in the follow-up of lesions after treatment. And finally, really stress the importance of a strong radiology-urology collaboration. So anytime we're doing cancer imaging, the goal is to find the tumor. If we can differentiate between indolent and aggressive disease, that's critical, but it can be difficult, and I'll talk about the role of ADC maps in that setting. Once we find the tumor, we must stage the disease, and MRI allows us to do that. And finally, once we stage the disease and we do the treatment, we have to detect recurrence, both local disease as well as metastatic disease. In regards to MR, the strength of MR lies in its superior soft tissue resolution with the delineation of the different zones of the prostate gland. We also have added on high-quality functional imaging to our high-quality anatomic imaging, and I'll talk a little bit about that. And finally, have been able to increase our resolution using endorectal coils in combination with phased array body coils. So the workhorse sequence in MRI, and specifically multiparametric MRI, is T2 weighted images. Tumors are going to appear low signal on the T2 weighted images, and that low signal comes from desmoplastic reaction as well as replacement of glandular tissue by tumor. The value of T1 weighted images really lies in their detection of hemorrhage and making sure that we don't call hemorrhage as tumor. So that's why ideally we'd like to wait 8 weeks after the performance of a biopsy before doing any prostate mpMRI imaging. Some of the other advantages of T2 weighted images allow us to talk about staging, specifically extracapsular extension or extraprostatic extension, involvement of the periprostatic fat, involvement of the seminal vesicles, which is key to diagnosing T3B disease, involvement of the neurovascular bundles, and finally involvement of the adjacent organs, including the rectum and the bladder. In regards to functional imaging, I'd like to focus on 3 different types of functional imaging today, the first of which is dynamic contrast enhanced MRI. The concept of dynamic contrast enhanced MRI is that we rely on the concept of angiogenesis and tumor vascularity to help us determine what is a suspicious lesion. And this increases specificity when combined with the high quality anatomic T2 weighted images. The caveat is that some of these tumors will not demonstrate increased vascularity, so we can't use dynamic contrast enhanced MRI or DCE MRI in isolation. Diffusion weighted imaging is the concept that tumors will have decreased motion of water molecules in part due to their increased cellularity. This is a technique that we use throughout the body and have now been able to use very effectively in the setting of prostate cancer. Small lesions can be problematic, but diffusion weighted imaging is definitely increasing in importance in high quality multiparametric MRI. The final functional technology I'll talk about is MR spectroscopy, and this relies on the premise that different tissues will metabolize different cellular metabolites in either normal tissue or in cancerous tissue. So normal prostate gland will have high citrate levels and low choline levels, while prostate cancers will show up with low citrate and high choline levels due to their high cell turnover. So now talking about some key clinical scenarios, specifically in the pre-therapeutic setting, the key ones that we'll talk about today are failure to diagnose, and that's specifically in the setting of anterior cancers. There's no question that multiparametric MRI adds a lot of value in the setting of anterior cancer, specifically in those where we've been unable to diagnose them with conventional methods. Active surveillance candidacy is an extremely important one in regards to both diagnosis, as Stacy Loeb was talking about, as well as in the follow-up of these lesions. And finally, focal therapy evaluation is something that is critical and something MRI can add a lot to. Pre-treatment planning is something we can add to as well, specifically in differentiating between T2C and T3A disease, but the first three is what we're really going to focus on today. So the first scenario, the first patient we'll talk about today, is a failure to diagnose. This is a 59-year-old male with an increasing PSA rising from approximately 4.6 in 2003 to 36.3 in 2013. This patient's done everything right. He came and had 4 prior trust-guided biopsies in 2003, 7, 8, and 11, all of which were negative for malignancy. So 48 cores all negative for malignancy. Patient was worried and he presented to Duke for a second opinion. So these are the images here that comprise our multiparametric MRI at 3 Tesla using an endorectal coil, the T2 weighted images on the top left, the ADC images on the top right, and the perfusion maps on the bottom. And what we'll see here is that there is a very large anterior cancer identified that is T2 dark, has markedly restricted diffusion, and highly suspicious perfusion kinetics. So this is a huge tumor, about a 3.5 cc tumor in about a 35 cc gland. And we ask ourselves, how does something like this get missed? Well, in this high-resolution sagittal T2 weighted image, we can really find out how this gets missed using simply systematic trust-guided 12-core biopsy. Typical biopsy throw, approximately 1.8 centimeters from the anterior wall of the rectum. Unfortunately, this tumor is approximately 2.4 centimeters from the anterior wall of the rectum. So with systematic biopsy comes systematic error. And this is an area where mpMRI can be extremely valuable. The second scenario we'll talk about is active surveillance candidacy. This is a patient who is 57 years old with a very different PSA trajectory than our last patient. 1.1 in 2004 to 3.2 in 2011. Did have a prior trust-guided biopsy which showed 5 out of 15 cores positive for Gleason 6 tumor, no Gleason 4 components on the right. Presented to Duke for an mpMRI and evaluation of being an active surveillance candidate. We see the axial T2 weighted images on the top left, the ADC images on the top right, and coronal T2 weighted images on the bottom to articulate and really show well the location of the tumor. Anterior right peripheral zone with mildly restricted diffusion, and I feel like you can see nicely on the bottom image that the capsule, or the thin black line overlying this tumor, is clearly intact. So based on this MRI, we were able to say that this lesion was in the anterior right peripheral zone at the level of the apex with restricted diffusion, but mildly restricted diffusion, and really nonspecific perfusion characteristics. We felt this represented a Gleason 6 tumor. We felt confident calling there no extracapsular or extraprostatic extension. And based on this, patient underwent a transperineal mapping biopsy. This did in fact confirm that he has 3 + 3 = 6 adenocarcinoma in the area of suspicion, and the patient was placed on the Parton tables. Based on the Parton tables, they were deemed to have an 84% chance of organ-confined disease. My contention is with a high-quality mpMRI, we can add that to that and feel really comfortable that this patient does have organ-confined disease. A 1% chance of seminal vesicle invasion, which again we felt the seminal vesicles were normal, and a 0% chance of lymph node involvement. So today this patient's on an active surveillance protocol, and they're on so with confidence, both the patient as well as the clinician. The final scenario we're going to talk about is focal therapy evaluation. So this is a 61-year-old male with an increasing PSA from 4.5 to almost 9 in 2012, had a negative PCA3 test in 2011, and had 2 prior 12-core biopsies, all of which were negative for malignancy, most recently in 2010. Presented to Duke for a multiparametric MRI, as well as for a possible transperineal mapping biopsy. As we take a look here at the T2 weighted images, the ADC map, and the perfusion map, we can see very clearly that there is a markedly decreased area of signal intensity along the left posterolateral peripheral zone at the level of the mid-gland, with markedly restricted diffusion and highly suspicious perfusion kinetics. Based on this, we can feel pretty comfortable that what we're dealing with here is the index cancer. Based on the degree of restricted diffusion, we feel like we're dealing with a high-grade cancer. And based on the degree of capsular contact greater than a centimeter, we can talk about the possibility of microscopic extracapsular extension. So we felt that this was a high-grade tumor. We felt that there was probable extracapsular extension here, and that's what we interpreted the MRI as. The patient did undergo a transperineal mapping biopsy, which confirmed that he did in fact have an index cancer at the site of the MRI suspicion. This was graded as a 4 + 5 = 9 adenocarcinoma. And based on the extracapsular extension and grade of tumor, at this time the patient was deemed not to be a focal therapy candidate and was weighing his options. One of the nice things about the radiology-urology collaboration here is that when Tom Palasic, my colleague from urology, speaks next, he'll give you a little bit of follow-up on this patient and some of the thought process as to why we would do what we do in these patients and how the MRI adds value to the care of these patients. So Switching gears a bit, I want to talk about how you integrate mpMRI into a focal therapy practice. So first and foremost, anytime we're talking about mpMRI in the setting of focal therapy, we must diagnose the cancer and characterize it appropriately. What does that require? It requires technically robust multiparametric MRI, high-quality images. It requires experienced radiologists. There's been literature showing that the value that comes from experienced genitourinary trained radiologists definitely adds value to mpMRI interpretation and adds accuracy. And finally, some form of structured reporting that allows us to integrate effectively with our urology colleagues, and that's a critical part of successful integration of mpMRI into your practice. How can you integrate mpMRI into biopsy and treatment? Well, the first thing you can do is do cognitive fusion. Cognitive fusion simply refers to the notion of taking the mpMRI results, realizing where the lesion might be, and then effectively aiming for those areas on standard truss-guided biopsy. An additional way of doing this thing would be to do a fusion biopsy, MRI ultrasound fusion biopsy, using software for lesions which can't necessarily be seen on truss, but do require a biopsy. And also this has value in the setting of targeted therapies. Finally, we can do MR-guided in-bore biopsies, which are for typically going to be lesions that are difficult on truss or difficult on fusion, and really more of a final problem-solving tool, and maybe for patients who have had negative truss-guided biopsies in the past. But certainly the tide is towards the fusion techniques in the beginning and less towards the in-bore biopsies at the end. So into practice building, you have to determine what is the best option for your group. We've determined that for us, the best option is high-quality MRI interpreted by the radiologist, and then mpMRI ultrasound fusion by the urologists. Another option would be to do some kind of MR-guided prostate biopsy or therapy by urology, radiology, or a combination of both. Anytime you're talking about practice building, you have to think about the financial considerations. And I think that some of the things you have to think about are the capital expenditure and the ongoing costs of a fusion system or in-bore biopsy. You have to model the opportunity cost on MRI scanners of doing biopsies as compared to diagnostic scans. You have to think about what are the new hardware and software availability that's out there in the marketplace. And finally, think about reimbursements as to how is your time going to be reimbursed and what is the most effective utilization of your time as a clinician and as a radiologist. So I want to show an example of an mpMRI ultrasound fusion biopsy case right now. This is a 66-year-old male with a PSA of 9.7, had no prior truss-guided biopsies, and presented to Duke for mpMRI and possible targeted biopsy. What we're certainly seeing here at Duke more often is the biopsy-naive patient, the patient who says, well, why should I undergo a 12-core random biopsy if I can get an MRI first and then get a targeted biopsy? And it's a question that we're faced with very often, and this is an example of one of those cases. So the patient underwent the MRI, and you can see in the top left corner, T2-weighted images, ADC in the top right, and dynamic contrast enhanced perfusion maps in the bottom. And what we can see here is an area of erased charcoal or lost glandular markings in the transition zone anteriorly on the left, restricted diffusion on the top right, and suspicious perfusion kinetics on the bottom. And what we basically do in a situation like this is, as a radiologist, we interpret the MR, and then we do pre-biopsy planning. We do 3D segmentation maps of both the lesion as well as the prostate gland. These images are then fed wirelessly into our system, our ultrasound MRI fusion system, and then it allows for biopsy. And this is an example of what that biopsy looks like. On the top, we have real-time ultrasound images. On the bottom, we have fused real-time mpMRI images. And on the right side of the screen, what you see is a depiction of where all the needles went, so about 5 or 6 core biopsies that were systematic core biopsies, as well as 3 biopsies that went right through the target. As we look at the results, we felt that this was a very high suspicion of a Gleason 7+ tumor on mpMRI based on the imaging findings. The fusion biopsy confirmed that this was in fact the index cancer, a 5 + 4 = 9 tumor, and so that's what we ended up seeing in this case. In regards to the role of multiparametric MRI in focal therapy, it's certainly been the subject of many meetings, including a meeting that Tom Plasek will speak about, which is a focal therapy meeting that we hold here at a combination of Duke, USC, and in the Netherlands. And what we need to really agree upon is the optimal imaging parameters. And the key question that arises is what should be the dominant sequence that is utilized? And I think you have to make a decision on that based on both the scenario that you're using mpMRI for, as well as the lesion location. We'll talk a little bit more about that. The next thing we have to agree upon is what is the optimal follow-up? Should it be biopsy, should it be MRI, or should it be a combination of both? And finally, understanding how follow-up may differ depending on the type of therapy used. What is going to be the most sensitive technique for detecting recurrence after cryoablation, after laser ablation, after HIFU, etc. So what I really want to focus on is dominant sequence dependence depending on the scenario or lesion localization. One of the good things that's happened in the past few months here is that PIRADS, which is a structured reporting scheme for prostate imaging, has recently been released, and it's given us some guidance about what dominant sequence should be used depending on lesion location as well as the scenario. So in the peripheral zone, the dominant sequence parameter should be diffusion-weighted imaging. In the transition zone, based on the types of tumors that we see there, T2-weighted imaging should be the key sequence parameter. And finally, in the setting of recurrence, dynamic contrast enhanced imaging should be the dominant sequence. So I'd like to show an example of the role of dynamic contrast enhanced imaging in the setting of PCA recurrence. This is a 70-year-old male who has a Gleason 7 prostate cancer diagnosed in 2007, underwent a radical prostatectomy in 2007 with recent biochemical recurrence. The PSA is now 6.11. In 2011, the patient underwent an MRI of the abdomen and pelvis, simply looking for lymphadenopathy. It was negative, and presented to Duke for a second opinion, as the biochemical recurrence was certainly very worrisome. So as we take a look at what a post-prostatectomy bed looks like, we have the axial T2-weighted images here and the ADC maps here. And the first thing we have to ask ourselves is, do we see any evidence of disease recurrence? It's an extremely complicated area. There's fluid levels, there's some hemorrhage, all sorts of things that are seen in that area. What we really need is a guidepost to help us figure out where is the tumor recurrence if there is presence. PIRADS version 2 gives us guidelines that the DCE would be very helpful. We use DCE in this particular setting, and what you can see is a hot spot or area of suspicious perfusion kinetics on the right side near the vesico-urethral anastomosis. And as we take a look here, we call the 1.2 centimeter lesion here highly concerning for locally recurrent carcinoma, no lymphadenopathy, but certainly something very suspicious for local recurrence. As I mentioned, the T2-weighted images and the ADC images were difficult to evaluate, but the DCE was extremely helpful. I felt so confident. This patient underwent a subsequent biopsy in this area, and it showed recurrent prostatic carcinoma. So to summarize, the role of multiparametric MRI in the detection of prostate cancer continues to increase, and it's really the multiparametric approach that's led to that. And some of the literature was talked about by Stacy Loeb. The keys are local disease detection, staging of disease, and distant disease evaluation. The concept of integrating focal therapy really revolves around finding the disease and determining what the best option for your group is. And finally, there's no question that there's an expanding role of multiparametric MRI in this setting, and we're fortunate to be part of the group that's helping to understand this a little bit better. I'd be remiss if I didn't acknowledge our multidisciplinary prostate team, led by Tom Polasic from Duke Urology. We've had great collaboration with our biomedical engineering colleagues, our pathology colleagues, some residents that have come through the Department of Radiology as well as in the School of Medicine. Other key contributors including our former director of MRI as well as our chair, the Coulter Foundation, and the NIH, which has been very gracious in funding our research. So with that, I'd like to thank you very much for your attention.
Thank you, Dr. Gupta. And now for Dr. Polasic's presentation.
I've been tasked with speaking about the integration of multiparametric MRI in active surveillance and the focal therapy paradigm. I wanted to start with a visual of what the problems are with the blind trust biopsy technique. And as you can see in the top screen here, the needle itself misses the tumor, which is depicted in red. In the middle one, the needle happens to hit a tumor, but it's the non-aggressive one. This leads to underdiagnosis. This patient may be inappropriately put on active surveillance. And in the bottom one, the needle hits the tumor, but does not detect the most aggressive elements. Again, this patient may be inappropriately put on a surveillance program. So the first thing is that we need to improve the prostate biopsy. As was mentioned by our former speaker, we do have a technique called the transperineal three-dimensional mapping strategy, in which it's done in the operating room. It's done through a grid, and typically 50 to 80 biopsies are taken. It's the biopsy that most closely matches and predicts final pathology, but it is morbid. Prostate cancer to date has been the only solid major neoplasm, does not rely on image-guided biopsy, but there are plenty of references now that support image-guided approaches being superior. So with this new approach with image-guided biopsy, two things are needed. First, you need accurate imaging, and we all feel that with multiparametric MRI we have this. And second, you need a method of targeting the lesion, and that's called MRI transfusion, where the MRI is merged with the ultrasound approach. Now, this approach can be used not only for diagnosis, but also later for targeted therapy. I wanted to mention a paper that Dr. Loeb had referenced. This is from Johns Hopkins. They looked at 50 men on active surveillance and got an MRI in them and found that with an MRI that was positive, there was a 40% reclassification rate at rebiopsy compared to if the MRI was negative, in which case there was only a 12% chance of reclassification. So even without using the MRI for targeted biopsy, MRI in and of itself adds value. You've seen these lesions before. This is what we call, as a urologist, the dark side of the moon tumor. This is a tumor that I don't think many urologists would hit with a standard office biopsy, as you'd have to actually push the needle all the way through the prostate in order to detect it. And this is what Dr. Gupta has shown already. As you can see here, you'd have to push the needle 2.4 centimeters into the prostate. There'd be no reason to do this unless you had an MRI that showed suspicion. Now again, the other option is that you can come from this direction here and place your needles like this. This is what's called transperineal, and we would typically take anywhere from 50 to 80 needle biopsies under the scrotum in this dimension, trying to find these anterior tumors. This is work done by my colleague Dr. Peter Pinto at the NIH, where he compared the 12-core standard biopsy to the fusion biopsy. And he looked at the MRI level of suspicion. As you can see from the bar graph on the left, if there's a low level of suspicion, it doesn't really matter if you're using MRI fusion or not. However, when the suspicion level increases as to moderate or even high level, the MRI fusion biopsy is much more sound and practical. This is Dr. Pinto and colleagues' group at the NIH reporting on their latest outcomes. This is published in JAMA this past year. And these authors showed that the sensitivity of the fusion biopsy technique was 77%. Now the question is, can we just do this fusion biopsy and replace the 12-core conventional biopsy? I don't think we're quite there yet. As you can see in the top right, when you combine fusion with standard biopsy, there's about an 85% sensitivity, so you do get a little bit extra sensitivity. This is what it looks like from a practical point of view. You see here in the top right photo, I'm working the ultrasound, my hands on the keyboard, and to the left of that is a separate device. It's our fusion system. Just below my chin level is a radio frequency transmitter that can localize where the needle is in space. On the middle image on the left, you can see the ultrasound image with the superimposed target, and then the bottom one on the left, of course, is your MRI image. So what it looks like when you're doing this live, this is the screen we look at. The bottom image is our MRI, and you can see our superimposed target on the MRI, and then we translate that image to the real-time ultrasound, and we translate the target. So you can see the target superimposed on the live ultrasound, and then we would do the biopsy based on the ultrasound. So the fusion biopsy and multiparametric imaging has certain advantages other than hitting larger, more aggressive tumors. We can also map these things in three-dimensional space and go back for follow-up biopsy planning. We can go back to the same area, and I think that's something that's new that we haven't been able to do before. At the Duke Cancer Institute, we also have an active surveillance protocol, as Dr. Loeb has described. we try to monitor and encourage all men that we feel safe that have a low-grade cancer to be monitored. We're even willing to take on some men with low intermediate features if they agree to follow our protocol. And as you can see, our protocol is heavily MRI based. We use MRI to characterize the tumors, and then we use the MRI fusion technology to target them. So then the question is, how do we integrate multiparametric MRI in active surveillance follow-up? Well, as Dr. Loeb has mentioned already, active surveillance also includes serial biopsies once you're on the protocol. At Johns Hopkins, they used to do these yearly. At Memorial in New York, they did it every 2 to 3 years, and in Toronto, perhaps every 3 to 4 years. The question arises then, if MRI can follow patients reliably and confidently, can we use serial MRI and targeted biopsies and replace the need for serial biopsies? This is a question that many investigators are currently addressing. The secondary question is the cost of these MRI scans, as they are quite costly in the US, but less so in Europe. Now, with anything new or novel, we need to keep an open mind because it challenges our traditional methods of managing prostate cancer. And I want to spend a few minutes talking about focal therapy. For many years, we've had a dichotomy of no treatment, as you can see on the left. It's either watching it passively or actively with active surveillance, versus the radical treatments we have on the right: surgery, radiation, whole gland brachytherapy, cryotherapy. But the question is, can focal therapy come in and occupy the happy middle? Now, with focal therapy, we have to utilize a number of avenues to roll this out safely. We have a number of centers throughout the world that are doing clinical research on this. This is a systematic review that my group, comprised of an international panel, recently reviewed the literature. Focal therapy comes in a variety of fashions. I just wanted to take a moment to explain them. The picture on the top right is where it all started back in the early 2000s. If we found a man with one-sided cancer, cancer confined to one lobe, and what you see here is a picture of the prostate, which is right here, and then you have the urethra here in the center, separating right and left sides, and you can see in the red you have the cancer, and each of these yellow dots on both sides represents the nerve bundle. So in this gentleman, he had a hemiablation. He had cancer on the one lobe, and we ablated the whole side. Then the question arises, can we ablate perhaps 3/4 of the gland you see in the bottom left, whereby we can almost eliminate the entire thing and spare the one nerve? And then on the bottom right is, well, how far can we really push the envelope? Can we do 99% of the gland and spare that nerve? That's a great question. We haven't really been able to achieve that from a practical point of view. But the way things are going right now is what you see in the top left, which is true focal, image-guided treatment, whereby we're only treating the tumor with a margin around it to ensure that we try to get all the cancer. Now, the flip side of all this is the active surveillance part. As we talked about, focal is a combination of treating the known cancer and leaving the rest of the gland alone. So back to our model of the hemiablation seen on the top right. If you ablate half the gland, by definition, the other half's on active surveillance. 3/4, the bottom left, you ablate 3/4, and you take a 25% risk with the other gland. But as you can see, with the top left, as you get more targeted with your treatment, you put more of the gland on surveillance and you take more potential risk for recurrence. So this is a cartoon depicting the various forms of focal therapy. Top left is near whole gland. The middle on the top is the hemiablation. The right is the 3/4. And then on the bottom three, this is the newer types of treatment we're talking about. The bottom left is treatment of 2 tumors in different parts of the prostate. The bottom middle is what's called quadrant ablation, and we're purposely treating the nerve on that side. And then the one on the right is the anterior gland ablation, and you're leaving both nerve bundles. So patient selection has been a work that people have been working on. We've had a number of consensus panels. This is a systematic review that my international group has written on. Bottom line is there's no consensus as of this publication back in 2014 for the ideal candidate. Earlier, most studies presumed unilateral disease. As I mentioned, we moved beyond that. At that time, we were using the bigger 50-core mapping biopsies, and we were just beginning to use MRI. However, a consensus in 2014 then showed that we should, as Dr. Loeb has stated, shy away from the low-risk patient because they're better suited for active surveillance. We then focused on the intermediate risk one. The volume's not a determinant since we're only targeting a small area, and we want the man to benefit from this treatment by having a life expectancy over 10 years. I wrote this article with my colleague Dr. Klotz from Toronto, who is a very strong advocate for active surveillance, and we both agree that there still are low-risk prostate cancer patients that could benefit from focal therapy in the area of active surveillance because the two approaches indeed can complement one another. So going back to the original prototype, which is the hemiablation, you see here we're freezing, these are ice balls. We're freezing half of the prostate. Here's the ice balls. We have two cancers located here. And I wanted to go over some of the results based on that original prototype. We can't really follow the PSA because we know the PSA drops by about 80%, but it doesn't really tell us very much, so we have to rely on biopsy. And as you can see, these are small studies, but 5 in the literature, and you look on the column on the right, we see a less than 5% failure rate on the treated side and up to about a 12% positivity on the untreated side, which is basically what we expect anyway. In terms of the complications, not many. Bowel problems, 0. The continence is upwards of 100%, and the potency in these studies was between 70 and 90%, with about half the men resorting to oral 5-phosphodiesterase inhibitors. This is a study reported by Duke Bond looking at focal hemiablation again. They found in their series 100% continence, 86% potency, and then they tried to do a matched pair analysis to look for men who failed focal therapy and might need further treatment. And when they compared the patients who underwent focal to a cohort undergoing radical prostatectomy, as you can see here with the p-values, it was not statistically different. This is a study from the University College of London group using HIFU to treat prostate cancer in a focal manner. Very similar results. The pad-free continence rate, 92%. The potency rate, 77% overall. This is a recent report on targeted focal therapy by David Crawford. He placed gold seed targets into the prostate and then targeted those. He found that at 1 year, 80% of the biopsies were negative, and he reported no adverse events, no incontinence, nor change in their sexual function scores. So you saw the prior cartoon of hemiablation, and what we're doing now in 2015 and beyond is dialing back at our treatment. So you can see here we're not running the ice all the way to the edge. We're now pushing that ice back further and only treating a smaller area of the prostate. Again, this is the patient who has the dark side of the moon anterior tumor. And the question is, what do we do with him? So, you know, I'm a surgeon at Duke, and maybe the answer is radical prostatectomy. But these patients, they want more of a guarantee regarding continence and potency, and what can we offer them? So this is a novel concept. This is an anterior zone cryosurgery for this particular patient. As you saw, his tumor was in the anterior zone here. We're running the ice down to here. We're getting nowhere near his nerve bundle on the left and the right. So this patient has an ideal outcome in terms of potency and continence. So what is the role of multiparametric MRI in a focal therapy program? Again, we turn towards a consensus effort of international experts comprising radiologists, medical oncologists, urologists, radiation doctors, and we have these reports. We're now focused on identifying the dominant or the index lesion. We're focused on intermediate risk cancers for the most part, and MRI can help find these tumors that are typically larger than 0.5 cc's, and as Dr. Gupta has shown you, a Gleason grade of 7 or higher, in other words, clinically significant disease. The MRI can localize them, characterize them, and put them in 3D space, so then we can go back and treat them. The other thing as a surgeon that I always want to know is, has the cancer escaped? So I find it important to know about extracapsular extension, or ECE. This study looked at patients who underwent surgery, so we know if there was extension outside the capsule, but they had a negative MRI. And it showed that using the targeted biopsy scheme, that was statistically significant for predicting extracapsular extension even in the face of a negative MRI. Once again, supporting the need for both MRI and targeted biopsy in combination. You saw this patient earlier. This is his MRI. When you look at this, you say, wow, this is a great candidate for focal therapy. I know where to draw my margins. I can do a quadrant ablation just like this, and that should be quite effective. But in fact, as Dr. Gupta mentioned, we biopsied this one, and it's a high grade, and we try to do the right thing for the patient. So he opted not to go with focal therapy and went with radical prostatectomy. So MRI can help both ways in finding candidates and finding men who are not candidates. So what is the role of mpMRI in focal therapy? This is, again, an international consensus panel. We should use MRI as the optimal imaging modality for follow-up after focal therapy. The first one should be done at 6 months, and then imaging yearly thereafter if possible. So what are some of the downsides? As was mentioned, MRI is challenging. It requires expertise and people who do this all the time. We still need more information on cost effectiveness. And finally, as Dr. Gupta mentioned, standardized reporting is really key, and we feel that we're there now with the PIRAD system. So bringing it all together, mpMRI improves risk stratification for active surveillance by clinically detecting significant disease, by directing biopsies to the lesion of suspicion, and it is also integral to focal therapy by identifying and localizing the index lesion, and for follow-up, targeted biopsies of that area. We're still working on an international collaborative group to push the frontiers of focal therapy. Our next meeting is going to be at Duke in June 2016. This will be our 9th meeting. It's an international working group of scientists, clinicians, radiologists, industry, medical oncologists, etc., those that are trying to make better treatments for men with prostate cancer. I thank you for your attention.
Thanks to each of you for your presentations. A quick reminder for our audience how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. The speakers will answer as many questions as time permits, and will follow up if we don't have time today. Okay, so we'll give you a few moments. If there are no questions, I would like to once again thank Drs. Loeb, Gupta, and Polasic for their presentations, and ask them if they have any final comments to share with us today.
Judy, thanks so much. I think that, one of the final comments I'd make is that I think it's very telling that today's presentation had 2 urologists as well as a radiologist in the presentation. I think it really shows the importance of the collaborative effort between radiology and urology to make this thing a very successful endeavor. I'm very lucky to have folks on my team like Tom Polasic who make who support mpMRI and really the role as it continues to increase.
I'd like to thank the audience for joining us today. And just a quick reminder, if you wish to obtain credits for today's session, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to the continuing education page where you can select a speaker, click on the CE CME button, and be guided through the process to obtain your certification. This webcast will be viewed on demand through March 30th, 2016. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.